Hello and welcome to Anaesthesia Skills Simplified with Dr. Rishabh Gautam. Let's make anesthesia safer, simpler, and smart. Many a times, our juniors are choosing inducing agent on the basis of their habit, but they are many a times not looking over the physiology of the patient. Choosing the right induction agent makes the difference between the stability and sudden collapse. Today we are going to discuss about the most common confusion among the juniors, that which drug to be chosen, whether Etomidate or Ketamine. Both of the drugs are stable, they are safe, but they are not interchangeable. If you are confused about whether to use Etomidate or Ketamine while inducing agent, then think about the physiology of both the drugs. Then only you will be able to understand which inducing agent can be used in the particular patient. So always prefer the safety of the patient. Safety of patient is always needs to be the priority. So let's have a quick overview of the both the drugs. Etomidate maintains the blood pressure, ketamine increases the blood pressure, and choice depends on the physiology, not habit. Consider it. Choice depends on physiology, not habit. So first of all, let's understand the pharmacology of Etomidate. Etomidate is an ultra short acting drug. It's an IV hypnotic agent. It's imidazole derivative. It has a very minimal cardiovascular depression and it has no analgesic properties. The dose of the Etomidate is 0.2 to 0.3 milligram per kilogram IV. Onset of action is 30 to 60 seconds and duration is 3 to 5 minutes. It's a GABA receptor agonist. Always remember the dose is 0.2 to 0.3 milligram per kilogram IV. But remember one point. In my previous video also I told you never bolus the inducing agent. Always titrate it. The slow hand saves the lives. You remember what we tell in the last video? Slow hand saves the lives. So always titrate. Don't bolus the drugs. The Etomidate has got some advantages of hemodynamic stability. It's good for shock patients. It is a minimal respiratory depression effect and it is neuroprotective as it decreases the cerebral metabolic rate of oxygen consumption and thus it is a neuroprotective drug. So other disadvantages of the Etomidate are adrenal suppression, myoclonus. The single dose of the Etomidate may lead to the adrenal suppression for about 6 to 12 hours, and it is happening because of it inhibits the 11 beta hydroxylase enzyme. So remember that single dose causes the adrenal suppression. So in cases of adrenal insufficiency, you need to be very careful before using Etomidate. It is also causing pain on injection and Etomidate has no analgesic effect. So when we use the Etomidate as a drug of choice for inducing our patient in cases of poor cardiac function, in cases of cardiogenic shock, in low ejection fraction, in cases of raised intracranial pressure, and for short-term ICU induction. Let's have a quick overview of ketamine also. Ketamine is a dissociative anesthetic agent. It has both anesthetic and analgesic and amnestic properties. It is giving us both analgesia and amnesia. It preserves the airway reflexes. It is a sympathomimetic drug. The dose, remember the dose. Inducing the patient, the dose is 1 to 2 milligram per kilogram IV. And for sedation, it is 0.2 to 0.5 milligram per kilogram IV. And I am telling you only the IV doses. I am not talking about the intramuscular or sublingual doses of ketamine. So the onset of action of ketamine is 30 to 60 seconds. It acts as an NMDA receptor antagonist. It maintains the blood pressure and heart rate, and it is a bronchodilator. It is a good analgesic. It is useful in asthma and shock patients. The disadvantages are increases the secretion It has related to the emergence delirium. It increases intracranial pressure and intraocular pressure. So be cautious while using this drug in patients associated with raised ICP or raised intraocular pressure. It is related with nausea and vomiting. So where we can use the ketamine? We can use ketamine in cases of trauma, in hypovolemia, and in septic shock. Where trauma, hypovolemia, septic shock. In bronchial asthma and for emergency rapid sequence intubation, you can also use ketamine. So before picking up the vial of ketamine, always look for few things. You have to be cautious in various patients, like the patients with severe hypertension, patients with the history of ischemic heart disease, patients with psychiatric illness, and patients with raised intracranial pressure. In patients with psychiatric illness, if you are using the ketamine, then it may lead to the emergence delirium. Quickly, let's compare both the drugs. Etomidate is hemodynamically stable, but ketamine raises the blood pressure and heart rate. Etomidate has no analgesic property, but ketamine has strong analgesic property. Etomidate single dose leads to adrenal suppression, and etomidate is preferable for cardiac patients. But ketamine is a bronchodilator and it's useful in trauma and asthma patients. So let's come to some clinical scenarios. If you are having a patient with a shock, both etomidate and ketamine can be used. If you are having a patient with asthma history, then prefer ketamine as your drug because ketamine is a bronchodilator. In cases of head injury, the choice should be etomidate because it is a neuroprotective drug. In cases you need analgesia, choose ketamine as preferable drug. Now let's come to the common mistakes that my young anesthetists usually do while inducing a patient. So before inducing a patient, always look for these things that you are not going to commit these mistakes. The mistake number 1 is repeated dose of etomidate in ICU. Sometimes our ICU physicians use etomidate for inducing the patient or for sedation also, but the mistake they are doing is they are repeating the dose. So please, I recommend don't repeat the dose of etomidate, as the single dose of etomidate leads to the it leads to the adrenal suppression for around 6 to 12 hours. Single dose leads to the adrenal suppression for around 6 to 12 hours due to the because it inhibits the 11 beta hydroxylase enzyme. So don't commit this mistake. Mistake number 2, using ketamine blindly in coronary artery disease patients. If you are using a ketamine in a patient with a history of coronary artery disease, then look for it that ketamine may increase the chances of ischemia in such patients. Mistake number 3, forgetting the use of anticelluloids with ketamine. Ketamine increases the salivation and secretions, so anticelluloid must be used with ketamine. One more thing here, I want to you to understand that not using benzodiazepines with ketamine may lead to emergence delirium. So always use benzodiazepine with ketamine. The two drugs need to be used with the ketamine while you are using ketamine as an inducing agent. Use both anticelluloids and benzodiazepines. Mistake number 4 is you are expecting analgesia from etomidate. Etomidate has no analgesic properties, and if you are thinking that your patient needs a strong analgesia and you want to use minimum drugs, you don't want to use opioid, then please don't use etomidate. If you want analgesia with using etomidate as an inducing agent, then you have to use opioid. You can't miss it. And the mistake number 5 is before induction you are not preparing your vasopressor. Always prepare your vasopressors before induction. Be ready for any kind of hypotension or sudden collapse, whether you are using etomidate, you are using ketamine, you are using propofol. Always expect hypotension or sudden collapse. So always prepare vasopressors before giving any induction agent. quickly memorize today's teaching is E, E, E for even BP, and use Etomidate. If you need even BP, you need stable blood pressure, use Etomidate. K for kick your BP. So if you want to increase the blood pressure, then use K for ketamine. K for kick your BP, K for ketamine. Quickly memorize the key takeaways of today's topic. First of all, there is no perfect induction agent. Choose the right drug for the right patient, and patient safety comes first. Always keep vasopressors ready. Never give boluses of the inducing agent. Always titrate it. Treat physiology and not the numbers. Do not go with the calculated dose of inducing agent. Always titrate it. Okay, so treat the physiology, not the numbers. And no, there is no single best induction agent. Induction agent always depends on physiology. So choose your drug based on physiology, not on habit. Thank you. Thanks for patient listening. If you like this video, then don't forget to like and subscribe the video. See you in the next video.